Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes. Welcome to another episode of Food, Freedom, and Fertility. We are your hosts, Caitlin Johnson and Sophia Pavia, both registered dietitian nutritionists who specialize in women's health and fertility. Me, Sophia Pavia, specializing in the 2-week wait, optimal progesterone production to help you get pregnant, stay pregnant, and have your healthiest pregnancy. And Caitlin, the PCOS goddess, specializing in helping women ovulate regularly, get pregnant, and have healthy pregnancies with PCOS. And today we have a guest / sponsor / the best in the biz, Dr. Gary Levy. He is the Chief Medical Officer for FertilityCloud, who is one of our proud sponsors here on the Food Freedom Fertility podcast. Welcome back, Dr. Gary. We're so happy to have you.
Thank you, ladies. Love being back. I love seeing you guys again. You guys look great.
Thank you.
Oh, well, thank you. We're wearing for those of you that are just listening, we have our Food Freedom Fertility merch on today. Mm-hmm. We got these for ourselves. So we have Dr. Gary here.
I love the alliteration, by the way. Food, freedom, fertility.
Oh, thank you. We love a good alliteration here. We
You're
really
do.
do.
Hear a couple of those today on the podcast.
We do. We do a lot of that.
Pulled up.
Oh, yeah, that's right. We do. We're starting a new thing. Listener, we have a new part of our podcast that we're going to do, which we call Connections Corner, where we take a break in our show and read one of your reviews back to you. So write us a review wherever you listen to podcasts, and you could be selected on our very next episode where we will read your review for all to hear. Good, bad, weird, we read them all. So leave us your review. We hope it's a good one, but, be honest. And back to the episode at hand here, we have Dr. Gary, who is our resident reproductive endocrinologist, fertility specialist, MD, in our pocket, where we're going to just take this episode and ask him what you wish you could ask your reproductive endocrinologist. We hear from so many of you that your doctor is in and out with one foot out the door, who doesn't really seem to have the time or bandwidth or interest, depending on who you're talking to actually listen to your concerns, to answer your questions, to educate you on what's happening in your body and what can be done to help you build your family. And today we have a whole hour where we get to just sit down with a fantastic doctor and essentially pick his brain on all the things that we know you are wondering about. So we got a juicy episode lined up for you today.
Thank you so much for the wonderful introduction. In defense of all of my reproductive endocrinology colleagues, there is a significant nationwide shortage, and I know they're all trying their best to help all of our
100%.
patients. Yeah.
100%. I really agree with you. And we're not here to dump on anybody, that's for sure. And I think that there are some really great hearts and minds that are getting absolutely crushed by our current medical paradigm. And it is sucking the joy of building families right out of their lives. And so hopefully we can pour into Dr. Gary here a little bit today. And learn some of the things that he has learned that he can help us lay people understand and answer some big questions for us today.
Yeah, absolutely. I look forward to it. I'm an open book today. Keep in mind, a lot of what I say is going to be based on evidence, but also my personal preference of how I practice and the interpretation of that evidence and how I apply it to the practical application to patient care.
And experience. That's another big, sorry. Well, okay. Cut that part out, Kylie.
Yeah, I mean, your clinical pearls of experience, how you interpret it with the patient in front of you, right? Because it's all patient-centered. It shouldn't just be like, this is the protocol. It should be, this is what we know, this is what we've seen work, and this is the patient and their goals and their needs and their background. And you kind of build something out of that.
There's a big difference between population-based statistics and then an individual response to whatever intervention or therapy we're applying to that particular individual. So majority of the time we see there's a correlation between the two, but not always. So we always have to be mindful of that.
Yes.
Amen. That is so true. And I think that in reproductive endocrinology, at least what I've seen in reproductive medicine of any kind, I call them zebras instead of horses because, when you're learning medical things, they always say when you hear hoofbeats, think horses, not zebras. Like
Mm-hmm.
it's most likely that you're going to see something common. It's most likely that you're going to see what the majority of the population has when they're experiencing whatever symptoms that we're looking at. But as I work with hundreds of women, I find that they're the ones that are the 2%, the 3%, the 5%. We say 95% of women who have X, Y, and Z, this is what's going on. Well, 5%, that isn't the story. And I see so many times that's who I end up working with, or people that just don't fit into, and then we're talking about a therapy that has 95% success rate. That's a pretty freaking great. But there still are outliers. And I find that you ladies that are trying to conceive and need extra help tend to be the outliers.
Mm-hmm. I
Okay, well,
absolutely agree.
let's hit it off with like, if you are alive, you've been hearing about these medications lately. Semaglutide or tirzepatide come in the form of things like Wegovy, Ozempic, Manjaro. Everybody's trying to get their hands on this for weight loss, weight management. Some patients of mine have asked my professional opinion about accessing these to help with weight loss so that they can either access FertilityCloud or meet some sort of recommended weight loss requirement that they've struggled to reach for an attempt at natural ovulation or ovulation induction medications being more effective for them. And I think there's a lot of questions and concerns about, can you be taking these while you're actively trying to conceive? If not, how long of a washout period do we need to let these medications work through their half-lives and us be really secure in knowing that it's okay to start trying to conceive? And, just hear your perspective and what you're seeing.
Are there potential fertility drawbacks to these medications? Because as they work in your body to burn more fat and to lose more weight, is it doing something unsavory to your reproductive organs or brain, which is a big endocrine organ in the process?
I love this question. I think it's a very important question. And I'm going to try to build a case for modification, lifestyle modification, and weight loss in general. Because the way we have to think about these medications, in my opinion, is in the context of where we are as a country with regards to the risk of obesity, diabetes, metabolic syndrome, all of those, what we call diseases of modern civilization in the United States. And so if you take a percentage of women and we're looking at a significant plurality now, not the majority of the US population overweight, obese, and suffering the consequences of those metabolic dysfunctions. And that has an impact on long-term health, it has an impact on longevity, it has an impact on lifestyle, it has a negative impact on quality of life, and it absolutely has an impact on what we deal with, which is um, fertility, ability to get pregnant, ability to maintain a pregnancy. One of the bigger neglected things that we deal with is that being overweight and being obese has a much higher risk for pregnancy loss. So nothing we do in terms of medical interventions with regards to, if you think about things like IVF, progesterone supplementation, et cetera, is as good as getting to a normal BMI with reducing the risk of pregnancy loss. So if you think about the context of where we use these medications are incredibly effective in combination with everything else that we are proponents of with regards to a healthy diet, an exercise program, and reducing weight and decreasing the BMI and getting to a healthier weight. And so from that context, they're great. I advocate for their use. with regards to getting to a healthy weight, getting to a healthy BMI, reducing the risks of being overweight and being obese, like diabetes, blood pressure, hyperlipidemia, and all of those things that we know are negatively associated with that. So the manufacturer is very explicit about where we have to be in terms of using them, stopping them, trying to get pregnant. And the recommendation is 2 months. So stopping use 2 months before trying to get pregnant. Now, that's an arbitrary recommendation. It's not really based on any studies because there hasn't really been studies looking at women who are pregnant and the potential negative impact or potential positive impact on those medications in pregnancy. So at this point, since we have a paucity of data, information with regards to how they impact pregnancy, are there increased risk of teratogenicity? Is there an increased risk of preterm labor? We simply don't know. And so because we simply don't know, the recommendation is to ensure that there's a washout period and those medications are stopped 2 months prior to pregnancy. So what do we do in practice? What do I do in practice? So for example, somebody who's going through IVF, hypothetically speaking, we know that ideal weight, ideal metabolic parameters improve their outcome with regard to egg yield, embryo development, etc. So I tend to keep them on as they're going through an IVF process. If they're going to have an egg retrieval under anesthesia, and the vast majority of women in the United States do have an egg retrieval under anesthesia, the anesthesiologists tend to desire for those medications to be stopped about a week before because we really don't know how they're going to respond under anesthesia. But the big concerning complications, because those medications slow the process of gastric emptying, there's a higher potential risk of aspiration. We want those to be stopped prior to any kind of surgery, and most women have anesthesia with their egg retrieval, for example. And then if they're going to freeze embryos, for example, they freeze a cohort of embryos and they're still not at their goal weight, my preference is for them to continue until their goal weight, because being at their goal weight really optimizes their prognosis in terms of embryo implantation, having a positive pregnancy test, and then that reduction in pregnancy loss, even with euploid embryos as well. So that's how I think about using those medications. That's how I use them in clinical practice. And I feel like that's my appropriate approach to people being on them and using them basically in the combination of tools that we have to optimize people's health.
So when you say to get them to their goal weight, is that variable? Are you looking for a particular BMI or just a percentage of body weight reduction?
So there's actually an absolute BMI, and then there's obviously relative reductions in BMIs. And so it's going to be personalized for everyone. Ideally, people are under 27, 26. That's not achievable for everyone. We're looking at 5 to 10% reduction in depending on where they are.
And do you have a preference if you were to utilize one of these medications between a semaglutide versus a tirzepatide?
I do not. I think tirzepatide works a little bit better, but it just depends on what they're able to get insurance, what's cheaper for them. Overall, I think any of them are reasonable additions to what they're already doing, hopefully.
Well, let's take a break and hear from one of our sponsors, and then I have one or two follow-up questions to that.
We're taking a break to talk about our sponsor, FertilityCloud. In working with hundreds of you ladies, we have noticed a problem that has come up. I know it's come up for me, Caitlin. It's come up for your clients as well. And that is not only finding a doctor who is going to know how to help you, but one that wants to. We have a lot of issues here, and sometimes getting a simple blood test or actually getting a medication or talking to someone who's actually an expert in fertility can not only take an insane amount of time, but it can feel like you're fighting your doctor.
Yeah, or you're playing like Russian roulette to get in front of somebody who actually cares. We are so excited to be partnering with FertilityCloud because they have a solution for all of these frustrations. Just last week, I had a client that needed right now care, and we couldn't get her in front of an OB. And she got a same day appointment with FertilityCloud and spoke to a reproductive endocrinologist and had a prescription that she needed in her hand hours later. This is a solution that our industry desperately needs, and we are so excited to present to you.
So if you're in a remote area and you have to drive 4 hours to go see a doctor, or if you've been to multiple doctors and none of them seem to really listen or really care or want to take an approach that works for you, start up with My Fertility Cloud.
My Fertility Cloud has provided us a link, so check it out in the show notes. That will get you $25 off your first visit with one of their providers.
We're taking a quick break from this episode to talk about one of our sponsors, the Prenatal Nutrition Library.
We love the Prenatal Nutrition Library. It's a searchable database and app, which means you have answers within seconds and peace of mind that what you're eating during pregnancy is both safe and nutritious.
It's almost like having your own personal pregnancy dietitian in your back pocket that's going to not only tell you, is it safe to eat this? How much of that should I have? Yada, yada, yada. But give you actual meal plans so you know how to put it all together onto your plate today. And the meal plans are trimester specific, meaning, some women are kind of nauseous in their first trimester and maybe they need specific foods to help combat that. Prenatal Nutrition Library has got you covered. Or the fact that your baby's brain is growing rapidly in your third trimester and you need your nutrition to support that. Prenatal Nutrition Library meal plans has got you covered there too.
This is evidence-based information. Registered dietitians are in this app weekly answering members' questions. There's an exclusive podcast within the app that's run by Ryan, who is the prenatal dietitian that founded this entire thing. It's a wealth of knowledge and resources and will take you far beyond that one-page handout your doctor handed you that actually probably has out-of-date information about eating in pregnancy.
So head on over to the Prenatal Nutrition Library as soon as you get your big fat positive. Well, okay, first message me and Caitlin so we can do a happy dance with you. Then head over to the Prenatal Nutrition Library to get clear strategies to meet your nutrient needs, as well as to take the stress out of confirming what's safe and most optimal for you and your baby while you're pregnant. Use code FFF20 for 20% off.
We're back from our break and we have some questions and thoughts. My first question is, what are your thoughts, Dr. Levy, on kind of this cult-like run to online doctors who can prescribe, and if somebody's struggling to get medical coverage with their insurance, because these medications do come with a pretty high ticket price if it is not covered. They're moving to compound pharmacies where they can get a vial for $200 to $300 and largely don't have a lot of oversight. I had a client who told me a few months ago that she didn't tell her IVF clinic that she was taking it, and I was concerned. So, I think with the advent of something beautiful like an e-commerce, telehealth type setting, that Fertility Cloud actually offers a real solution in these scenarios. There's kind of the dark side of that, of the web, where it's like too easy to access something, not enough medical oversight for something that is a pretty, something that should be managed medically. So thoughts on that, especially in the context of somebody trying to lose weight and trying to conceive, and maybe they're not protecting against pregnancy.
Well, anytime someone's using a prescription medication, especially as something as novel as these new classes of drugs, I think it should definitely be under the oversight of a physician that has experience and interest and an understanding of what these medications do. Now, that being said, I understand that's not always possible. And for the vast majority of women taking these medications for short courses, they're likely not going to significant side effects or complications as far as we know now, because again, there hasn't been data on them for 5, 10, 15 years.
Mm-hmm.
And the manufacturer has made a decision with regards to recommendations in women who are trying to conceive. And that those recommendations, like I previously said, they're based on just a paucity of data in pregnancy. There are case reports of women being on them in pregnancy. Most of those case reports have not demonstrated any significant problems within the pregnancy, but they're only case reports, so we cannot make any medical decisions based on those things.
Yeah, and when we talk about something being teratogenic or having a problem in pregnancy, it's a pretty narrow scope of what we're looking for. We're looking for like spinal cord defects, limb differences, really big measurable problems, and not necessarily the things that come down the line for kids that we really don't have great explanations of why people end up with brains that work differently and problems that can come up. And
yeah, absolutely right. It's a medication that has a lot of metabolic effects, and so you brought up something during a commercial break, which is an excellent point. Brain, ovary, they're primarily fat, cholesterol, organs. There's a lot of metabolic activity that happens. If that's amended, is there going to be a significant cognitive impact down the line after delivery? We simply don't know. We simply don't know. And so again, the recommendation is to try to, or to, not to try, but to prevent pregnancy if a woman's on these medications. And so I would have to agree with that current recommendation. That may change in the near or distant future, but the current recommendation is if you're trying to conceive, to not be on these medications for at least 2 months prior to that. Now, what somebody can attempt is that somebody can be on these medications and delay trying to conceive because the benefit of losing weight, for example, is going to improve your chances of conception, potentially reduce your risk of pregnancy loss in the future. So from that perspective, I would agree in using those medications.
I think part of the issue as a dietitian is for the individual that is taking it as if it's a miracle drug and not doing what you have stated at the onset of this, that there are lifestyle modifications, behavior modifications that need to go hand in hand. Like I have watched an individual not trying to conceive, but a friend of mine who has decided to take Wegovy and lost 60 pounds on it successfully, feels so much better. Mental health is better, physically feels better, lab parameters are improving, but there have been no recognizable behavior shifts. There has been appetite suppression. There has been GI side effects that have made food less appealing. And so as soon as she gets cut off from this medication, I foresee a very quick rebound in weight gain because her appetite's going to come straight back and she's not going to have an upset tummy anymore all the time that's holding her back from eating food. And so I think it's really important that individuals that are considering something like this understand that this is being approached as a medication you need to be on long term to maintain or at least wean yourself off of it, spread out the dosages so that you can work on some of the behavior changes that you have hopefully put in place while taking the medications, so that you can successfully kind of titrate off of them to maintain at least some of the benefits that you've achieved while on them. And just expecting it to be like that new magic thing, just pay $300 and give yourself a shot once a week. It really isn't that simple. And I would even argue working with somebody like a dietitian or who understands things like gastroparesis, when your stomach does empty more slowly. Okay, well, how do we want to modify your diet so that we can acknowledge that and make sure that you're getting the nutrients that you need?
That is exactly what was coming to mind for me as we're talking about this, is getting the nutrients that you need, because we have episode on episode on episode about eating enough protein, eating enough choline, getting enough vitamin A, getting enough vitamin D, getting enough iodine. I mean, the list goes on. And not only that, the antioxidants from colorful fruits and vegetables, the fiber that your digestive system, your liver needs in order to function. And when you're grossed out from your medication and just not really eating, and so you're sort of like snacking on crackers and having some bites of sour candy and sipping a diet Sprite, and that's what you're having. Meanwhile, you're losing all this weight. It's so nice. Your body, your ovaries, your uterus, your liver, your brain, and then the nutrients that your baby needs down the line, they're just not there. And so continuing to eat a fertility friendly diet, even when you might not be feeling so good because of these medications, that's really something that comes to mind for me. First and foremost is the people that I've seen really step away from a lot of the foods that are supported. Because when you're kind of queasy, are you going to be eating like kale and eggs? No, you're going to be eating like a freezer waffle for breakfast because you just are feeling kind of icky. And when you have a stomach bug and when you're overcoming a nasty cold, well, that's fine because we're talking about like a week out of your life. But when we're talking about months on months on months on purpose because of medication, now we're looking at nutrient issues that are going to contribute to the health of your baby and the health of your pregnancy down the line.
Yeah, absolutely right. And in my opinion, freezer waffles should never be eaten.
Listen, they have a place. I'm telling
you should be making my high protein version
exactly.
and freezing them yourself.
Caitlin has the best freezer waffle recipe. Truly, that is so nutritious.
It's got like
and
3
very
eggs
yummy.
per waffle. So, you're
They're
changing
always
it around.
in my freezer.
Yeah.
When you ladies come visit me, you'll have to bring some for me.
Yes, we will do
not
that.
the Eggo ones. Not the
no. We don't play with that.
Manufactured ones.
No, we
And
understand.
really we're here to talk about like best practices and making a sanctimonious statement like best is very relative. And so depending on the amount of weight you need to lose, what you've tried, where you're at, your particular barriers to pregnancy, a medication like one of these GLP drugs may be worth the risk in some situations, or it may not be. And it just is nothing is ever going to substitute the proper diet and lifestyle. It's just not going to happen. And so if you think this is your fast route away from it.
Yeah, from your perspective, ladies, I apologize for interrupting you.
No, go ahead. I talk too much.
And you guys are dietitians, so you guys are much more closer to that front line of getting people to lose weight than I am. I'm already getting them when they try certain things and they're already on the medication, et cetera. And so what do you feel is the biggest obstacle to initiating those modifications, identifying the proper foods? Because I think we all have to acknowledge that everything starts with the diet, right? So diet is the most important thing.
I have some quick thoughts
first,
on
Caitlin.
that. One thing that is so prominent in diet culture is the idea that it has to be this extreme. And if you're not implementing Whole30, paleo, ketogenic diet, some extreme form of intermittent fasting, but instead you're just eating a high protein breakfast, going for a walk after a meal to make sure that your muscles are pulling in a lot of those quick access to glucose and impacting your insulin levels after a meal, like that's not sexy. And it's not what people see like, oh, well, my friend went keto and lost 40 pounds. And so that is one kind of frustrating piece where it's like, I'm trying to implement something that's not sexy, but I know works. We just need to work on it for more than 4 weeks to get you results. And that mindset of just the modern culture we're in, we want quick and extreme has this appeal to it because it hasn't been the thing I've done before. So maybe this is like the golden ticket I've been missing. That's one piece of it. I think another piece of it is time and people feeling, I don't agree, but they feel like they don't have enough time to make the changes. So spending the time in the kitchen. But they are happy to sit on their couch in the evening and scroll TikTok for an hour and a half. And so an investment in time and even maybe even flexing the muscle of learning a new skill in the kitchen.
It's a big one.
Because by and large, I mean, if you really want to be successful in behavior change, you're going to have a lot better time if you're eating a lot of those things from home versus eating out. You're just going to see benefits so much more quickly. And so I think those two things kind of compared together, it's like you have this burnout factor if you do something extreme, even if it has some tenets that would be great, like eating more whole foods like Whole30 has, and eating more eating more proteins, and you can pull from that. You can eat a really healthy fertility diet on something like that. But because you're not used to eating that way, typically people burn out really quickly. So having kind of somebody who often comes to me who's implemented a number of diets and none of them have worked, doing something slow, and we work on a change or two, you sustain that, we add in the next change or two. That appeal isn't necessarily there, but they're also 10 diets deep by the time they come to me, and they've royally screwed their metabolism usually by the time they come to me, because every time you do some sort of calorie restrictive diet, you're going to come off of that diet with a slower metabolism than you even started it, because you've reduced your calorie intake and you've lost some amount of weight, which isn't just fat. You're also losing lean muscle mass as that's happening typically, unless you're really protecting against that. And so when you're 10 diets deep, by the time you even get to something that is sustainable and well designed, we have a lot of metabolic rehab work that we have to do as well, in the context of already busy lives.
Yeah, I completely agree. I think when the word diet has different connotations, and I think it has to be changed to understand not a fad, but basically a lifestyle, right?
Yeah.
It's everything that you consume. And so my general recommendation to people who are trying to conceive or are trying to lose weight as they're trying to conceive is to try to you certainly cannot be militant, because you still have to enjoy your life. And our culture revolves so much around food. Every time we celebrate, we eat. Every time we meet friends, we eat, we drink. And so to kind of minimize alcohol intake, I think that's number one. The second is to try to minimize or eliminate any kind of sugary beverages. There's so much sugary beverage consumption. Yeah, and just that one change a lot of times makes a significant difference. But with regards to what you consume in terms of eating, minimizing eating out is a huge one. But at the same time, focusing on protein, lean protein, with less carbohydrates, or definitely minimizing processed carbohydrates is what I recommend. It may not be the exact fertility diet that's out there in the textbook, but I feel like we have more success with those recommendations because there's still a lot of variety that people are able to consume and enjoy what they eat when they're eating protein. So there's steak, bacon, fish, stuff that typically you'd want, a hamburger, but just maybe not eating the bun, minimizing the processed breads that are attached to everything, but in combination with some sort of physical activity. And I feel like those are simple enough recommendations. They're diverse enough recommendations where people aren't restricting what they eat. They tend to be somewhat more successful.
Yeah, restriction really is something that pretty much every woman who's trying to conceive at this date in time has tried. Those of us that were born in the 80s, 90s and went through the whole low fat craze, went through the whole low carb craze, went through the whole everybody idolizing Nicole Richie and Paris Hilton and the Olsen twins and these ultra skinny gals, where being as skinny as possible was the goal during all of your formative reproductive years when you were going through puberty and shortly thereafter. It is really hard to let that go and say, no, we're no longer going to try to be as small as possible. You're going to try to be as fertile as possible. And for people with PCOS, like what Caitlin works with, there is often insulin resistance, stress intolerance. There are other issues that can make it more challenging to lose weight. And especially when they're given this,
to gain it.
And oh yeah, way too easy to gain, especially when they're on these like calorie restrictive, high intensity exercise, programs that they're trying to fit into their already crammed work schedule, and they're getting 4 hours of crappy sleep and relying on caffeine, and just really tough with someone with PCOS. I, in working with women, yes, sometimes women with PCOS, but more focusing on progesterone, that your luteal phase, the 2-week wait in early pregnancy. I see that sometimes gaining weight is necessary, and sometimes no weight change at all. I see women that are in overweight categories where their doctors say, here's the reason you're struggling to conceive is because you're overweight. And they change how they eat, they change their rest, they change their exercise, and the scale barely moves, couple pounds maybe, or doesn't move at all. Yet we see greatly improved fertility parameters. We see people that are now ovulating much more regularly, much more robustly. They're having 12 plus days of a luteal phase. The spotting is so much better. The insomnia is better. The progesterone reactions that I see a lot of women having, the like histamine intolerance that comes in that luteal phase where they're like itchy and hot at night, that gets so much better, and they get pregnant, stay pregnant, go on to have much healthier pregnancies. But we really didn't see the scale move at all. Or a story like mine, where I actually put on weight and lost muscle in my trying to conceive journey inadvertently because I hurt my back and couldn't lift anymore. But that really contributed to me being able to get pregnant. And so I see that happening a lot too, that just simply adopting this fertility supportive diet, fertility supportive lifestyle, you may not see drastic changes on the scale, but you can see drastic changes in your fertility. And that's part of, oh, amen, overall health. Because we preach it here every day. Fertility health is health. And that's part of why, I mean, sometimes we knock IVF because we're like, this is not solving a health problem at all. This is just getting you pregnant. And so if you're not healthy enough for pregnancy, forcing one is not the answer. And so that is a whole separate issue. But fertility health is health. When you're healthy, it's easier to get pregnant. And I had this whole conversation with one of my group coaching patients yesterday because she has having so many fertility issues. And I was like, look, fertility aside, if you never wanted to have a baby, ever, you were the next Mother Teresa and having children is not on your list. Having these issues, like having PCOS, that is a metabolic illness that needs to get addressed, even if motherhood is the furthest thing from your mind for your life. These things you still need. Having prolific endometriosis, having a uterus 5 times its normal size because of adenomyosis. These are health problems that need to get addressed, even if you didn't ever want to be a mom.
Yeah, completely agree. Completely agree. And then optimizing your health, again, allows for improved probability of success, whether it's spontaneous or with any kind of reproductive intervention. So there's no downside to doing it.
To optimizing nourishment
we say
and
that
nutrition.
A lot too, like, and what are the risks? You want to talk about the risks to these GLP medications? You would talk about the risks to fertility drugs? Talk about the risks to IVF, to you and your baby? They're there. You want to talk about the risks of eating eggs
Broccoli
at breakfast?
Not...
You want to talk about the risks of replacing your Eggos with Caitlin's protein waffles? What, it took an extra 45 minutes from your life to batch this out?
Well, let me ask you guys a question. I know like we came on the show to talk about something specific, but I think this is important. As we grew up in 80s, 90s, early 2000s, we were given a very particular guidance with regards to what we should eat, like the food pyramid, if you remember. In my opinion, it was a disservice to us because it's all wrong.
It's upside down almost.
Yeah, for real.
And so the people that gave us that guidance are, essentially still in charge of providing those recommendations to us, to people. And the people that go to these trusted websites, they go to the government websites, they following their guidance, they're not really seeing a change, their health isn't getting better, then they're getting placed on these medications, which are somewhat successful, fairly successful in getting them to lose weight. It's just this cycle where people aren't modifying their lifestyle, they're not eating nutritious food. And so it's like a hamster wheel that a lot of people don't really can ever leave. And so this is very frustrating for me as a fertility doctor, because you have to get people to like de-learn what they were taught from like what we are supposed to consider trusted authority.
And years and years and years and years and years of eating and developing habits and opinions and preferences. And I think another thing that happened in that time frame is moms really went to work. And so it was the TV dinner era or drive through the drive through. And so, sitting in the kitchen with your mom while she cooked and learning those skills is also something that entire generations have really missed out on. And so it's a multi-layered thing. Add in socioeconomic status and food deserts, we've got additional problems. But
add in the general confusion that people have when it comes to this, because you can talk to
10 different dietitians.
Yeah, talk to 10 different dietitians and get 12 different opinions.
Yeah.
It can be really, really difficult because you have one person saying, beef is so healthy for you. It's got B12 and iron and zinc and all these things. It's a fertility superfood. And then you have somebody saying beef is poison. It's full of toxins and dioxins and murder and every other bad thing. And it's just like, what am I going to do? Drink water and put my feet in the soil and hope to just start photosynthesizing? Because that's the only thing that I haven't heard a disturbing documentary about on Netflix.
Fair enough. I think as a general rule, right, we can avoid processed foods as much as possible, eliminate sugary beverages as much as possible, stick to whole foods, focusing on protein as much as possible, or as much as
protein and veggies. I mean, you're not going to go wrong there. Can I reel this back in a second?
Yeah,
because
absolutely.
You are our voice, our mouthpiece for FertilityCloud. What if somebody, and like, hear me now, this is not me saying everybody run and make an appointment for this medication, but if somebody were like, hey, I know I have 80 pounds to lose before I can do X, Y, or Z, and I'm focusing on fertility, is FertilityCloud a resource to get a medication like Ozempic, Wegovy, GLP-1 agonist?
So our practice at FertilityCloud primarily focuses on improving lifestyle. We talk to our patients, like almost all of our patients, about the appropriate exercise changes and dietary changes. We do ovulation induction or superovulation if necessary. We have not prescribed any of those medications at this point, simply because we don't have at this point the bandwidth to do that. Because those people really have to be taken care of and monitored appropriately. And so we don't offer those at this point. We might in the future if we're able to have the capacity to do that. We just don't have the capacity to do that properly. And I don't believe in just prescribing them. And
Amen. Yeah.
This is why we love FertilityCloud. Listeners, hear us now. Okay. These medications are a freaking gold mine for a lot of doctors, and they are jumping on this to try to pay off their astronomical student loans. Dr. Gary could be one of those people easily. FertilityCloud has all the prescriptive rights one would need in order to do this. But he, and as their medical director, the doctors working beneath him, aren't doing that because they do not believe it is best for the patient at this time. And so there you go. This is a doctor who genuinely wants to properly monitor his patients, who is concerned about their long-term health, not just a pregnancy rate that he can tell the world
on a
about.
Website.
Exactly. This is why we love FertilityCloud. And for those of you that were hoping this was just going to be a doc in the box that you could just call and boss them around and get whatever prescription you wanted, the wrong guy. That's not what's going to happen with FertilityCloud. These are genuinely wonderful doctors who are looking for your well-being first and foremost, not the bottom line.
You're absolutely right. And we really appreciate the kind words from you about our enterprise. That being said, if we are working with somebody for a long time and it tends to be the appropriate next step, we may consider doing it, but we just don't write those prescriptions at this point as a general rule.
Love it.
We have to focus on nutrition because
Nutrition
those are the
is,
building blocks of
yeah,
everything.
foundational issues associated with and movement. I think nutrition and movement are similar. But
And they're so underrated
I
because it's not going to
completely
get you
agree.
pregnant next week.
Well, not next week, but and that's I think there's a culture issue that you've touched upon. The instant gratification has been made worse with our access to social media because everything is instant. And so, how a cultural change is I think, foundationally the hardest thing to do. Whether you're taking over organization or obviously the United States, we're just we're basically at this point run on processed food. And so, how do we decouple from processed food? It's very difficult to do because so much business is dependent on it. And the rest of the world is becoming catching up to us with consumption of processed food because it's so convenient, right? And we don't see the downsides for 5, 10, 15 years of just consuming processed food. So, not all. I'm not
Yeah, the
at all.
ultra processed
Yeah,
bag of
yeah,
fluorescent
yeah,
red Cheeto level
yeah,
processed. Yeah,
yeah.
we're not
And then
talking
if
about buying a spaghetti sauce in the grocery store or like buying
exactly,
a
yeah.
pre-cut
hmm
mushrooms.
But that's, I think, what 60 to 70% of what people consume is ultra processed foods. So
Mm-hmm.
hopefully, I mean, we have to start making those fundamental changes because these drugs or these fad interventions, they don't optimize health. Like, and then people get older, they're immobile, they're in constant pain, their cognition worsens. It's like the quality of life gets worse.
So let's take a break from our episode to do our next commercial break. And then I think Sophia has some rapid fire questions for you.
Sure do.
Wonderful.
We
I
can
look
switch
forward to it.
gears from metabolic drugs to frequently asked fertility questions.
Hey guys, we're taking a break from our episode and I want to talk about something that's super confusing. When you head down the supplement aisle and you're looking for a prenatal, and on the prenatal bottle itself, it says, do not take if you're trying to conceive, pregnant, or breastfeeding. Like, what the heck?
It says talk to your doctor if you are pregnant, could be pregnant, breastfeeding, postpartum, whatever. And every supplement has this. You go down the supplement aisle, you go shopping on whatever supplement website, and there's a disclaimer on every bottle of every single thing, which means that everything that you've been taking your whole life long is now a big question mark about whether or not you are potentially harming yourself by taking something where you're trying to be healthy. So that is why we partnered with Needed. Needed is a perinatal nutrition supplement brand that has a wide array of products specifically designed for women who are pregnant, trying to become pregnant, breastfeeding, or postpartum. So it's not just that these products like can work if you're in that situation, or oh, it's probably okay if you take it while you're trying to conceive. No. These products are researched, they are formulated, and they are put together specifically for women who are trying to conceive, pregnant, breastfeeding, and postpartum.
This answers so many questions. I always get asked, like, what can I take? It's cold and flu season. What's safe? Needed has an immune support. That's safe whether you're trying to conceive, pregnant. It's even safe for your little ones.
And it's not just immune support. They've got collagen, they've got hydration support, they have digestive support, they have prenatal multi. They even made a line for dudes.
Needed is somebody we're really proud to be partnering with. So head over to their website and use code FFF20 for 20% off your order.
Welcome back. We are going to do our next little section here, Connections Corner, where you send us your reviews and we read them back to you. So this review is coming from Sarah071418, and she gave us a shining 5-star review titled The Best. Sarah says, I always look forward to my Monday morning commute because I know that I will get to listen to Sophia and Caitlin. I'm guaranteed to laugh at least a couple times throughout the episode, which is an added bonus to receiving a plethora of information each week. Love listening to their advice and wisdom. Sarah, we love that you are listening.
Yeah, and we love hanging out with you in the car. We're your besties with our green teas in the morning. So thank you for writing in. One thing that's something we got to weave in here, Dr. Gary, Sophia, we got to give him a laugh or two so Sarah's not bored.
Yeah.
So
well, put in what I was just yammering about when it comes to Dr. Gary's surgical tools, and everyone can laugh at my idiocracy.
Okay, rapid fire.
All right, Dr. Gary, I hear questions a lot, especially some surgical questions. I recently have had a big onslaught of gals that are dealing with possible adenomyosis, possible endometriosis, and there is sort of a cutting edge new test that is out there. And I would love to hear from the horse's mouth, what is this test? How accurate is this? And just sort of what the average Jane needs to know about this sort of biopsy of the uterus that's looking for some kind of protein, as far as I know. Can you shed a little light on this?
And maybe before you even jump into that, define adenomyosis. I think most people know what endometriosis is, but
oh yeah,
not everybody knows adenomyosis.
Yeah, absolutely. So endometriosis and adenomyosis is kind of a spectrum of conditions, and there are a multitude of theories of how they end up or proliferate, but none of them typically is accurate in describing all cases, because men can get endometriosis as well, and there's endometriosis in the brain and the lung. But the primary theory behind endometriosis in the pelvis is what we call retrograde menstruation, where anytime a woman menstruates, there's some retrograde flow into the fallopian tube and into the pelvis, and then there's some immune dysfunction where the immune system doesn't clear those cells, and then basically they attach and spread around the pelvis on the ovary, and then become hormonally responsive as they would be inside the uterus. And that's endometriosis. And adenomyosis is basically those cells perforating through the endometrium and into the muscle of the uterus, or basically those cells being deeper where they're supposed to be anatomically. And again, they're responsive to the hormonal signals that they would naturally be responsive to if they were in the normal endometrium. And so what does that mean? Does that matter? It means that some of these women can experience pain in a cyclical manner. Some of these women can experience abnormal bleeding. Some of these women can experience pain when they're intimate. And there's a specific proportion of these women that will see a decrease in the probability of success when they're trying to get pregnant, whether spontaneously or they present with infertility, and our interventions become less successful. And so there's a spectrum of presentation. There's a spectrum of how the disorder or the disease manifests itself, whether it's gynecologic symptoms or fertility or subfertility or even infertility. Some women present as what classically is described as like a chocolate cyst, where there's a collection of those endometriotic
Not as
cells.
delicious as it sounds.
Yes. Well, I've never tasted it, so I don't know.
Okay, there it is.
That's a disgusting joke I should not have made, and you just took it and ran with
You
it.
lobbed it up, and he knocked it out of the park.
Right. You put it on a T-ball for me.
I did. Okay, all right. Moving on.
Yeah. So, although I'll tell you a funny. Can I?
Yes.
Can I go on a funny story tangent? Yeah. So
always.
So when I was in residency, I think I was a second or third year resident, and fertility doctors, you have to go through an OBGYN residency, and you were doing an emergency C-section for a woman who had a placental abruption. What that means is the placenta basically tears off the uterus, and it's a surgical emergency in some cases. And so the uterus fills with blood and it's under pressure. And so it was me and my co-resident that were doing this emergency C-section. And I remember it just like yesterday. She cuts into the uterus and it's under so much pressure, it basically just explodes, and all this blood goes flying, hits the ceiling, goes right into her mask. And then it feels like, essentially, like, her face is covered. It was just a scrub out to finish the case. But that reminded me of that.
Good God.
Yeah. It's never dull in medicine, that's for sure.
No,
that is crazy. That is crazy. And here women worry about pooping when they're pushing out their baby. That's the least of your concerns. And some women actually go to get a C-section because they're afraid of pooping when they're pushing.
Yeah.
Wow.
And here you could be making your surgeon gargle with your uterus blood.
That's right.
What is the scarier scenario?
I certainly advocate towards vaginal delivery the vast majority.
Dude, amen. Wow,
Anyway,
that's quite a story.
So getting back to endometriosis or adenomyosis.
Get back.
So we know that there is tissue in an ectopic place, so basically in a place where it doesn't belong. It's responsive to the hormones that it should be responsive to. And there's immune dysfunction in women who have that because theoretically and technically those cells should be cleared out by the immune system. And these women have abnormal pain signals because they tend to experience a much higher amount of pelvic pain because of the endometriosis. So there's like a spectrum and basically a constellation of things that endometriosis and adenomyosis can present like.
Well, when we're talking about the fertility aspect of it, because most women, they're like, I would endure periods from hell if it meant getting to have a baby.
Right. And so there is a biopsy that we look for that we can do in what we call the luteal phase, the phase after ovulation, where
we know about the luteal phase.
Yeah, I know you're an expert
on this podcast.
Yeah, and so we send the biopsy to a specialized lab that can stain certain proteins, and then if those proteins are positive, it basically means that those women are more likely to have endometriosis or adenomyosis.
So tell me about these proteins that they're looking for.
Well, they're basically called like BCL6, which is a certain proteins that are overexpressed that they should not be. And when we correlated in women with endometriosis, we found a really, really high correlation. I think it was Bruce Leslie's lab that did the original work, and he actually came to talk to us a couple of years ago in our institution. And so for how does endometriosis impact fertility? So from one aspect, it can be so extensive that it can compromise ovarian reserve, meaning like replace the actual ovarian cortex where the eggs are with endometriosis tissue. It can also become so extensive where it blocks fallopian tubes, so it forms a mechanical obstruction. But most of the women don't have any of those like really catastrophic problems. Sometimes what ends up happening, you go to get an endometriosis surgery, and it's so extensive that the ovaries are removed or enough healthy tissue of the ovaries removed to improve endometriosis symptoms. So you end up with compromised ovarian reserve. But also those are pretty rare. Like if somebody's going to have a surgery, that's a discussion that they need to have prior to actually having the surgery. But in general, we know that there's like decreased egg quality. We know that there's a decreased response to fertility interventions, and there's a potentially higher risk of miscarriage. So it's behooved upon us to identify that before we intervene. And so this test potentially for a lot of women gives you, it's not a certain diagnosis, but it's a higher likelihood that yes, endometriosis is present if a person is not successful, for example, with successive fertility treatment. And so typically what we see is if a woman screens positive for this test, if we medically or surgically treat her endometriosis, we see a better response. And so what does that mean? So some women have to have a laparoscopy where a surgeon or a reproductive endocrinologist or a minimally invasive gynecologic surgeon or an OBGYN, who the vast majority of people that do the surgery should be skilled and experienced in doing it, and remove as much endometriosis tissue as visible.
Not ablation, excision, right?
Well, when you say ablation, you can ablate the endometriosis with a laser or excise it, and we typically see similar results. And if we use a laser and ablate as much of the endometriosis as possible, because the laser is much more precise than removing it with scissors, for example, or burning it off with other cautery, we tend to have better results. And so I like to use the laser for endometriosis surgery because in my hands it's a little bit better and I can get more endometriosis cells removed. But it depends on what the surgeon uses most and what they're comfortable with, because you really want the surgeon to do the same thing. And so you're going to go to a surgeon that uses a particular tool. You want them to use that tool.
So let's talk about adenomyosis.
Mm-hmm.
And because I've had a group of ladies lately that just were given such horrible prognoses from adenomyosis. And I'm hoping to breathe a little bit of hope their way in this situation. So can you talk about interventions for adeno, what it is, and why it's so difficult?
Well, can you give me like a little bit more information about, like,
Little
for
case
example, how were they
history?
how were they
Yeah, okay.
diagnosed, etc.
Okay, case history. So we have a 32-year-old female with never a pregnancy. She has done multiple rounds of IVF. She's done 3 transfers so far, all unsuccessful. She has a history of continual uterine polyps. They just keep coming back and keep coming back. She also has a lot of UTIs, and that's another issue, is that every time she's intimate, a UTI is happening, and more polyps all the time. And so what she recently had done was the protein test that you were just talking about, and that with just some ultrasound imagery of that big boggy uterus made them say, okay, this is adeno or adenomyosis, and the only course of action that we can do is get rid of the polyps, and then as soon as you're ready for another transfer, we'll first put you on all these meds to help with the adenomyosis, then do a polypectomy, and then a transfer as soon as possible, and then if that doesn't work, another round of IVF, and do this exact same course of action every single time we do a transfer.
Yeah. Okay. So adenomyosis, as a general rule and in principle, is a very difficult disease to treat because we don't really have good surgical intervention to remove it, because it's not a discrete fibroid, for example, in uterus is discrete, and if it's interfering with the anatomy of the uterus, it's fairly easy to remove the
Discrete
fibroid.
meaning in this situation, not like whispering very politely, meaning like it's well-defined,
Correct.
accessible to excise.
Yeah.
That's what they mean, just for the average listener.
Yeah, and so I think depending on what the imaging shows, so there's a spectrum of treatments for adenomyosis, especially someone who's had multiple failed, advanced fertility treatments. Typically, there is a medical intervention with the intent of shrinking the adenomyosis in the uterus, and the general medication that we use is just GnRH agonists or antagonists. And what they do is they block the brain's production of hormones that stimulate those cells appropriately in the uterus, but when they're invasive into the muscle of the uterus or outside of the uterus, that stimulation causes them to grow and become inflamed and kind of do what they're supposed to do, but they're in the wrong place, so they're pathologic. And so if we remove the stimulation for those cells, a lot of times we see a reduction in the volume, how much of the adenomyosis burden there is in the uterus, and we tend to see some improvements in follow-up IVF treatments. The issue is that it's not, certainly not perfect, and it's very difficult to quantify how each individual patient is going to respond. There are some surgeons who are very good at removing adenomyosis. So again, as a general rule, because it's a much more complicated surgery, there is a higher probability that surgery where we actually incise the uterus and try to remove as much adenomyosis as possible may result in a complication that can only be controlled with a hysterectomy. So a lot of people don't recommend that. And somebody who is at the point where she's had multiple failed transfers and really, really wants to get pregnant with her uterus, that may be the next option at this point.
Find somebody that does these adenosurgeries left, right, and center, who's extremely skilled with them.
And most of the time, these surgeries are going to be open surgeries, because a lot of times you have to feel the adenomyosis with your hands to kind of know where to stop the excision, versus a lot of the gynecologic surgeries are done currently with minimally invasive approach, and they should be. But again, because adenomyosis is kind of this insidious invasive issue into the uterus, think the best outcomes, if they're going to have surgery, is probably with a laparotomy or an open surgery, is what we call it. Not
Wow.
ideal, obviously, but if they're at the point where nothing really worked, that may be the next step. Again, depending on what we see on imaging, and if we see something that we really can potentially remove.
Scary, but
Informative.
okay.
Yeah.
Scary, but informative.
Yeah, we don't always advocate surgery, but sometimes surgery is the appropriate course of treatment.
That's what I was thinking as well. I just got this one gal that I can't get out of my mind. Who's,
Okay. And if you if you were interested in referring them to our, I'd be more than happy to review the imaging, the treatment course up to this point, and maybe make the appropriate recommendation, whether it is surgery or not, depending on what's been done to this point.
So let's talk about that.
Okay.
What if you are someone who, like I had somebody yesterday that I met with that had done ovulation induction, multiple rounds of IUI. The next thing was IVF, and nobody had talked to her about things like nutrition. Nobody had talked to her about things like weight loss, frankly. They went straight to IUI. And, I think there is a growing population of women who are willing to try to advocate for really great care and maybe more opinions than just one. And some people feel like their purse strings are tied, and so they need to stick with one particular course. Others may not. And I'd love to hear kind of your insight as to how you can go about doing what you just offered. If this has been your case history and you want another, piece of eyes on this and some recommendations, FertilityCloud is an awesome resource in that regard. And frankly, really accessible in all the ways you need it to be, in the comfort of your own home, at a price point that's actually very affordable for the expertise that you're providing. And appointments usually within hours, most days.
Exactly.
At this point in time.
Because that is a really big, I'm going to say here, just for the listener, this is a really big fear. This is actually the case study that I just presented you. A concern as well for that patient is that, they're in for a penny, they're in for a pound with their doctor. They've gone so far with this doctor, and they've done so many treatments. The fear of coming to another doctor who is just going to start them at square one and is going to run them through these incredibly invasive tests that they feel they've already had done or whatever. Basically that they're setting back their clock again. That they're just going to, that starting up with someone new is going to be costly in the worst possible way for women who are trying to conceive, which is taking away their only unrenewable resource, which is their biological clock, time.
Well, I certainly hope to provide some reassurance to anyone who's listening that that's not the case. There's absolutely no reason why you should abandon your doctor if you seek a second opinion. In my opinion, the more medical opinions you have, the better off you're going to be. And we always encourage a second opinion. If somebody comes to me and we develop a treatment plan, but they're skeptical and they really want somebody else to weigh in on what we recommended, we always encourage them to find
I love
another.
that. This is rare. That is rare, Dr. Gary. I have patients right now in my care that their doctor says, if you're going to go to somebody else, don't come back here. And this is a doctor that they feel terrified of because they still have 3 embryos frozen with the doctor that said, if you go to somebody else, don't come back here.
Well, that's unfortunate, but that's not the atmosphere that we provide at FertilityCloud or anywhere that I've ever practiced medicine. Because my ultimate desire is for that person to be successful. And if somebody else plan gets them a higher chance or better chance, then by all means, I want them to do that, and then I'll learn from whatever that individual recommended for them, and maybe incorporate into what we do. So we do not have any negative feelings towards anyone that seeks a second opinion or a third opinion or a fourth opinion somewhere else.
Reproductive medicine's not a competitive sport for you, huh?
Not for me, because Yeah, because again, my goal is the same as the patient's goal, is to make sure that they get to where they want to be as fast as possible. But also, to give them the best possible care. And sometimes it's seeking an alternative opinion and choosing a different route that, for example, what I think needs to happen. But what we do, and for somebody like that particular individual, they may continue with their physician, but our conversation may generate some additional questions that they may ask their doctor or request of their doctor that may lead them on the right path forward in their treatment. And it doesn't mean that they transition somewhere else, but it may mean that they have a more educated conversation. So I feel
Or
that
be
if they,
reassured that it is a great next step or
yeah,
the only next
That,
step.
absolutely.
yeah. We were talking before we started recording this episode about my husband who is in the process of medical retirement due to some spinal problems. And that was our best case scenarios. We did seek multiple opinions, and what we really were hoping for basically is that the first doctor's opinion would be echoed by the second specialist.
Hmm.
And so that's often what you want to hear before you go into something as drastic as an open uterus surgery or an IVF retrieval or these
Hmm.
things that have extreme implications not only for your life but for generations to come. Somebody that's going to give you an alternative or even say, I don't
Hmm.
know, but I know someone who does. Let me send you to this other guy who
Hmm.
I studied under. If you've got this or that, he'll find it.
Hmm. Yeah, absolutely. I completely agree. And keep in mind, a lot of times things change as well. And so when you go see somebody else, they may have just looked at something up very similar to your case that may
Mm-hmm.
move your treatment forward a little bit better, or reinforce and provide some reassurance about the opinion that was already rendered. So it's never wrong to do, and I always encourage it.
So, on the topic of uterusi, how do you say uteruses? Plural.
Uteri?
Uteri,
Uteri. It's like
uteri,
octopi, but with
octo,
two T's.
uteri.
Listen, it's not uterus. It's uteri.
Oh, that's right.
I'd
Not
love,
us.
I'd love to tee up a question, and then we'll take our final commercial break. Something that I see a lot in my practice with mostly people that have been diagnosed with PCOS is abnormal patterns of bleeding.
Hmm.
And what I will describe here is somebody who may have ruled out polyps, ruled
Hmm.
out fibroids. They have abnormal patterns of bleeding that is just like, I'm bleeding on end. Like, I
Hmm.
bled for the last 65 days. And some days it feels like period bleed, and some days it's just spotting, but they're spending more of their life bleeding than
Hmm.
they're spending not.
Listener, this
Which
was me before when I was first trying to conceive. I had this situation.
So, I have thoughts and things that I've recommended to individuals because I see a lot of this. But I'd love to hear from your medical perspective, like what types of treatment could be offered to an individual like this,
Hmm.
maybe what testing you would do, and just kind of your fertility doctor perspective on it. But let's take a break and then
Of
we'll
course.
come back and cover that.
Hey, it's me again, Sophia Pavia, registered dietitian nutritionist specializing in women's health, fertility, and optimal progesterone production. And I'm interrupting an episode of my own podcast to tell you about my online course called Ovulation Unlocked. So if you've been listening to our podcast episodes, you've probably heard a lot of things about basal body temperature, cervical mucus, cervical position, and tracking your fertility. Well, I have designed a 90-minute self-paced online course, which I titled Ovulation Unlocked, that puts all of that together and teaches you how to be the expert on your own fertility from home. This course is designed to put you in the driver's seat of your own fertility, not only so you can know what's going on with your body on any given day, but so that if you need medical help, you can show up to the appointment informed and ready to communicate. Too frequently, us women show up to our doctor's appointments and just say something like, I want to have a baby. And the doctor looks at you and says, good for you. Stop using birth control, start taking a prenatal, come back in a year if you're not pregnant. And that's all we get. However, Ovulation Unlocked puts you in the driver's seat, puts you in control of your fertility to where if you need help, you can show up to that appointment informed and ready to communicate your needs. So if you want to become the expert on your own body and your own fertility, head on over to my Instagram bio and tap the Ovulation Unlocked link today.
All right, we're back, Dr. Gary. What do you think about that?
So in women who have abnormal bleeding and we know have PCOS, typically their bleeding patterns are because they're not ovulating. And so regular predictable bleeding is a result of this very unique symphony of hormones that develop the egg, ovulation happens, progesterone is released from the corpus luteum for a finite amount of time. If the pregnancy doesn't occur, progesterone drops, and we have a predictable menstrual cycle, 3 to 5, however many days. If in women who have PCOS, that kind of the amplitude and the wavelength of how the hormones are secreted don't allow for egg maturation in most of the cycles. And so what ends up happening, instead of that rhythmic exposure to estrogen followed by progesterone, globally speaking, that allows for predictable bleeding, what ends up happening, there's a continuous exposure to lower levels of estrogen. And so the lining basically builds, and then begins to slough off at unpredictable and irregular periods. And that's what these women are experiencing. And so if they're actively trying to get pregnant, obviously we do an evaluation to make sure there's no precancerous cells, there's no other anatomic abnormalities like fibroids or polyps that are potentially responsible for irregular bleeding. And so if they're trying to get pregnant, then everything else is sufficient to start this intervention. We typically will want to get them to ovulate on a predictable schedule. And one of those things is obviously lifestyle modifications, certain supplements that we recommend for women with PCOS that kind of act like metformin, which is an insulin-resistant medication. And so that's kind of the initial step. Now, if somebody's trying not to get pregnant, what we really want to do is expose the lining to progesterone on a
predictable.
Exactly, on a rhythmic scale and a predictable schedule. So that lining is stabilized, and they're bleeding either on a predictable schedule, or some women elect not to have periods, and that's perfectly fine. And so they're on continuous progesterone, whether it's a pill, an IUD, or et cetera, other interventions. The downside of any medication that we offer women is that the most common side effect is unpredictable spotting. And so that's unfortunate because we're treating symptoms, but then one of the most common complications is also spotting.
That same symptom.
Yeah, the spotting is less than the bleeding. And then there's going to be a group of women that will have complete amenorrhea on long-term progesterone, and they won't have any bleeding. And some women definitely prefer that. Some women want to have a period even if they're on medication. So basically, my recommendations are depending on what the goal is of the patient and then kind of what they want. If they want to have cyclical bleeding, we basically just take them off their progesterone for a certain amount of time. If they don't want to have cyclical bleeding, but they're counseled and they understand that they may have unpredictable spotting, which should be less than the symptoms they're having, then they're satisfied with that. But there's a variety of interventions that we have. But the important thing, if women are bleeding in unpredictable periods that are concerning, is to make sure that there isn't any anatomic cause or like a potential precancerous cause.
Like polyps, fibroids.
So you would refer to a local doctor that could do imaging?
Well, if they're seeing us, for example, at FertilityCloud, we could always order ultrasounds for them. And then based on what we see on ultrasound, we can potentially refer them for, like, if we are really concerned that somebody needs a biopsy of the inside of the uterus, like the endometrial biopsy is what it's called, or ensure that their pap smear is up to date, we can certainly refer them to a local OBGYN or primary care physician that can do that.
So when you say cyclically introduce progesterone. So we're kind of trying to mimic what would happen naturally versus just slapping someone on a birth control as an option, which is an option as well, right?
Yes, absolutely. And the most common medication that's prescribed for this is birth control. Now, if birth control has more side effects than progesterone alone because you're putting somebody in higher doses of estrogen, overwhelmingly it's safe, but it does have more side effects in relation to progesterone alone. So if somebody is, for example, using barrier contraception, doesn't want to take birth control, my preference is progesterone only or a progesterone only contraceptive pill, but they have to
Actual
take
progesterone, not a progestin, that like in
that.
these.
It depends on what the patient wants. I mean, most of the commercial medications that are available are indeed progestins. So things like medroxyprogesterone, which I don't like to use, or norethindrone, which is my preference as the progestins. But I present the options, and then if somebody wants to use a progesterone, then we go with that. If somebody doesn't really have a preference, then a progestin tends to be a little bit cheaper and more commercially available.
So is that something if a client was experiencing or a listener's experiencing and they're not actively trying to conceive, is that something that FertilityCloud would be happy to partner with somebody in? It doesn't have to necessarily be specifically for building a family.
Correct. Yeah, absolutely. I mean, if somebody has a GYN issue and then they're interested in getting care, we are not going to turn somebody away because they're not actively trying to conceive.
I think one thing that this brings up for me, especially in this PCOS population, and I want listeners to hear that I am in major favor of this. If you are not bleeding, you are amenorrheic, you have increased risks of a lot of things. And a lot of times your OBGYN might be talking about cancers, but it goes far beyond that. Your progesterone is good for your bones. Progesterone is good for your mood. Progesterone is good for sleep. Like your body needs exposure to progesterone in these fertile years, like half the time. And if you are oligomenorrheic or not having any cycle and you're never ovulating, so your body's not making its own natural progesterone, you need some plan or course of action coupled with somebody that can prescribe you progesterone so that your body can be exposed to it. And then hopefully, I guess there's an option to just stay on it, but have the opportunity of a menstrual bleed in that way. One thing that I see really often is OBs prescribing it to a clientele that's trying to conceive and working on behavior change to induce ovulation. And it's almost like they're prescribing it too frequently because they're not allowing for enough time for a PCOS
I see this quite a bit as well. They'll just start taking, or I see this with a luteal phase defect, is they'll be given a bioidentical without instruction, and they'll just take this every day.
And then, and when your body is exposed to that progesterone, it oftentimes and shouldn't ovulate on its own, right? It's like we're mimicking that natural process.
Yeah.
Well, yeah, it depends. So progesterone on its own, if taken for a certain amount of time every month, isn't going to be a birth control. Like ovulation can still happen and women can still get pregnant. But, if it's taken off cycle, then it becomes essentially like a birth control. So if women are trying to get pregnant, you're absolutely right. They need very specific instructions of when to take that medication. But if they're ovulatory, theoretically, and there's no identifiable luteal phase defect, they hopefully do not need any supplemental progesterone. So in women who have unpredictable bleeding and they're trying to get pregnant, but they're, for example, don't want to take ovulation-inducing medications and they're kind of on progesterone for endometrial protection. And what I would say is progesterone is the preferred intervention, not a progestin in those women. And then I don't really recommend them taking it if they don't know when they're going to ovulate. So my preference is that they have some sort of an intervention to induce their ovulation in addition to that. But, it's not for all women. And so the easiest thing to do is that just have them take it from the 10th to 20th or the 15th to the 30th of each month. And that can potentially compromise their ability to get pregnant. So there is some discussion that needs to happen with their healthcare professional or physician, OB/GYN, reproductive endocrinologist, is how to specifically manage each individual case.
Right. Because I mean, I often see as people are working towards natural ovulation, if they're not ovulating at all, it might take them 45, 60 days their first cycle. And usually that shortens over time. But if we always intervene at day 14 or we always intervene at day 30, a lot of times the doctors will say, if in a full calendar month you don't have a period, take a course of the progesterone. A lot of times we're kind of jumping the gun on what their body may be actually working towards. And in my practice, we do a lot of cervical mucus tracking and basal body temperature tracking. Sometimes, depending on their LH patterns, we may also do OPKs. To where it's like, well, if you're in a really good cervical mucus pattern right now, and I know you're supposed to be taking your progesterone soon, let's at least see this play out and see if your temps rise and maybe see ovulation take place.
Yeah, that's exactly right. Like, you don't want to prematurely expose your body to progesterone before ovulation, because that obviously will interfere with your ability to ovulate. So
it's
once
a big
that's
deal,
confirmed,
cut
go
me
ahead.
out.
Absolutely.
No,
Go ahead.
okay. I was just saying it's a really big deal because bioidentical progesterone is the semaglutide of the luteal phase defect people. People think that this is the cure, this is the panacea, and getting on a progesterone supplement is going to get them pregnant and do everything and more. And it's just not reality. And taking it at the wrong time, taking it in the wrong doses, taking it inconsistently, using it in forms that are actually not approved for fertility. I see people all the time buying these like creams and such from beauty websites or from compounding pharmacies. And first of all, they're unstandardized because it's a beauty product and not a medication. Secondly, the absorption is different depending on if you get sweaty, if your clothing is rubbing it off, if you have other creams and lotions and things on your body. You could be really giving yourself a wildly varying dose of something that is not even approved for fertility purposes because you've been hearing about how important progesterone is and you think that this is just going to be the thing that gets you pregnant. It's not your prenatal vitamin that you just...
No. And if you're getting it from a company that is a multi-level marketing oil or supplement company, this is not what we're talking about here, and it's not going to do the job that Dr. Levy has so eloquently described some of the benefits of, especially in these cases of long periods of bleeding. So
it's not good for your body. It's not good for your relationships. You're not going to become a millionaire selling it. It is not a business opportunity. It's none of these things.
Yeah.
As a general rule, transdermal or oral progesterone, so anything you put on the skin or take as a pill orally, is not really effective for reproductive issues. And so if we're going to take
let's make that the headline of the episode.
We're going to take, and some women need progesterone for reproductive issues. That should be taken either vaginally, the vast majority of cases, or intramuscularly. For reproductive purposes. The vast majority of the cases, vaginal is sufficient. But oral progesterone is good for hormone replacement therapy, for example. Menopause. Yeah, but not for like pregnancy support.
Great. That is wonderful to hear echoed by a professional of your caliber, because that's exactly what I've been seeing in experience, in evidence, and in education. So that's
Wonderful.
Good to hear. And you can... we
love you, Dr. Levy.
Oh, yeah. Sorry, cut me out there. We do love you, Dr. Levy.
Love you.
We have soaked up enough of your precious time because we know that you have got patients out the wazoo knocking on your door hoping for your help. So we can wrap this episode up
let's give you an opportunity to tell us a little bit more about FertilityCloud, because you guys have so generously decided to sponsor our podcast this season. We love partnering with you. I tell so many women about FertilityCloud. I just it's the resource I am so thankful that we have.
Absolutely. So Our original mission was to make fertility care and reproductive care as widely accessible as affordable as possible. And obviously, the most logical thing was to put it on telehealth for everybody to have access to. And so we offer a comprehensive treatment, evaluation and treatment for essentially most of reproductive issues associated with ovulation induction, superovulation, insemination, and even in vitro fertilization as needed. So we really would like to see as many people as possible access our service if needed. And so by all means, come enjoy and then hopefully get some good results from your experience.
Do you want to highlight a recent case maybe of somebody that came to FertilityCloud and just give us like a brief case study of somebody that you were excited to work with?
Yeah, absolutely. So one of the recent patients that we had was a patient who kept on having failed IVF cycles, and similar to what we discussed, wanted a second opinion. We reviewed everything, recommended certain tests for follow-up. He took those recommendations to our IVF doctor, obtained those tests, identified some issues with the embryos, created new embryos, and then was able to transfer those and got pregnant and had a baby. So similar to what we talked to in the past, it doesn't mean if you come to us that you abandon your doctor, or you could potentially get some additional information to make you more successful locally.
I love that.
Yeah.
I love that.
Well, let's roll into our yeah girl and our my man. So I will go first because I want to, and that is that in
do it.
6 short days, I will be in New Orleans with my best friend on the planet, Miss Caitlin Johnson. Caitlin and I are doing a podcast retreat in New Orleans next weekend, and I am so excited. And this is piggybacking a second yeah girl, which is I've recently finished my very first round of the Pro Luteal Lab, which is my group coaching program for women that are looking to strengthen their ovulation, strengthen their ovulation, strengthen their progesterone production so that they can get pregnant, make it through that 2-week wait, and have a healthy pregnancy beyond. And so I'm really relieved. That was a lot of work. I was really scared about how it would be received and how these women would go, and meeting with so many people and doing group coaching versus individual, but we did it. And now I am retired, and I'm going to go enjoy some good food and good friendship with Caitlin in New Orleans next weekend. So I'm pumped.
Yay. Yeah, girl. I'm ready for it.
Yeah, girl.
Beignets. That's going to be my yeah, girl.
Yeah, beignet girl.
Dr. Gary, do you want to go next?
And can I do yay girls, not yay girl?
Yeah.
Okay. So I want to do a yay girls to Caitlin and Sophia first for having me on the podcast. I think you guys are great, and certainly appreciate coming on the podcast and talking about all the things that I feel are important. And also, I think you guys are doing great work focusing on very, very important foundational issues in terms of health and reproductive health. So, yay, girls.
Oh, we'll take that.
We will take it.
We will take that. Okay, mine is, we had like this parenting conference at our church this weekend, and my mother-in-law very often takes my 6 and 4-year-old girls over for sleepovers. But this week she was like, I want to see if Seamus will come too. So my 2-year-old boy had his first sleepover at grandma's house, and it went without a glitch, which means my husband and I can like go do a weekend away sometime. So, yes, yeah, Johnson.
Yeah, Johnson.
So
that's exciting. My mind is like whirling now.
I'm doing my yeah girl for my mother-in-law. Yeah, she's the saint of the saints. She's like, and I'm doing yeah girl for a weekend away with my husband sometime. Long overdue.
Well, let's tell you what. If you get along with your mother-in-law, that's awesome.
I do. She literally is like, I hear a lot of people bemoan really sad situations, and I am a very blessed woman. And she will likely listen to this because the other day I was like, oh, did you know I went on an outing with your brother-in-law, like my husband's uncle? Like, he showed me around Wichita, his favorite places. And she's like, oh yeah, I knew. You talked about it on your Instagram stories. It's like, she is my super
That's
fan.
happened to me. I'm like, ooh, okay, I need to make sure that I don't say things that I don't want you to know about. So that's good to know.
And where can I get merchandise? I'd like to get a hat.
We will send you some merchandise.
You've earned
it will
one.
Be once we hit stop, I will get your address and it will be in the mail.
Absolutely.
Okay. Well,
absolutely.
I really appreciate it. Thank you, ladies.
Yeah.
Thanks you so much for coming on. We hope to have you again next season.
And again.
Absolutely. Your expertise, your knowledge, your heart towards women of reproductive age, they are unmatched. And so truly, thank you from us and from our listeners. Hey, it's Sophia. If you love the show and want to continue your health and fertility journey using our resources, head on over to foodfreedomfertility.com for show notes, links to products and services, information about our guests, and our newsletter. Again, that's foodfreedomfertility.com. Thanks for listening.